Hello, everyone, and welcome. We'll give it just a couple minutes while we allow more people to join. Hello, everyone, and welcome to those who've joined already. We'll give it another minute or two as people are slowly joining, and then we'll get started. Hello, everyone. Good morning, good afternoon, and good evening, and welcome to the fourth of our four-part Amplify Projects Global Dissemination webinar series. I think we'll go ahead and get started. We've got a packed program, even though people are continuing to join. My name is Eva Lathrop. I'm the Senior Director of Reproductive, Maternal, Newborn, and Child Health at JPIGO. And in this role, I get to provide clinical expertise in support of the Accelerating Measurable Progress and Leveraging Investments for Postpartum Hemorrhage Impact Project, or AMPLI-PPHI. I'm an obstetrician gynecologist with over 25 years as an educator, researcher, and public health practitioner, working in diverse global settings while continuing to provide clinical care at home. It is my pleasure to be chairing today's webinar, Catalyzing Systemic Changes to Improve the Availability and Affordability of Postpartum Hemorrhage Products. Today's webinar will summarize the project's work to improve availability and affordability of postpartum hemorrhage products across 6 countries. It will explore the distinct access challenges facing heat-stable carbetocin, or HSC, tranexamic acid, or TXA, and calibrated drapes, and outline the market and health system solutions implemented to address them. The session will highlight government actions in Kenya and the DRC to enhance access to quality-assured medicines and project contributions to broader efforts to strengthen the postpartum hemorrhage product market. Our session today will be about 90 minutes in length, with 5 presentations delivered by our distinguished speakers, followed by a Q&A and a closing session. Before we begin, there are a few quick housekeeping notes. If you have any questions, please click the Q&A icon at the bottom of your screen and submit them there. If you're unable to see that icon, please select the More box, the one with the 3 dots at the bottom, of your screen and then select Q&A. The box will then appear for you to submit your questions. If your questions are directed to a particular speaker, please make this clear when you're submitting the question so we know to whom to direct your question. Our presentations today will be in English and French with simultaneous interpretation. Please select the interpretation icon in the bottom corner to listen to your preferred language. If you cannot see this icon, again, select the More box with the 3 dots and select interpretation there. And finally, closed captions are also available. To enable this, select Show Captions, turn on translation, and select your caption language. Our first presentation is from Ms. Elaine Roman. Elaine is the Global Project Director of the AMPLI-PPHI project. For the last 20 years or more, Elaine has worked with global stakeholders and partners across a diverse set of countries to help support country efforts to advance maternal and newborn health outcomes. She has authored several publications on malaria and pregnancy, and more recently, postpartum hemorrhage. Elaine has also lived and worked in Kenya, Somalia, and Turkey, and provided both technical and programmatic support, focusing on improving maternal health outcomes in nearly 20 countries across Africa and Southeast Asia. She will ground our webinar with a brief overview of the AMPLI-PPHI project via a recorded presentation today, as she's unable to join.
Thank you, Eva. I'm sorry I can't be with you all live, but do want to welcome everyone wherever you are joining from. As Eva just mentioned, this is the 4th webinar in our series, and whether you are here for the first time or have joined us for any of the preceding webinars, the focus remains the same: disseminating key learnings and practical knowledge that you can use. Up front, I want to thank our donor Unitaid and the European Union for their complementary support. I also want to thank all our partners and ministries of health who have driven AMPLI-PPHI from the start, building on many years of country leadership to advance maternal health outcomes. As Eva mentioned, and to get us started, I have just a few slides to ground us in the AMPLI-PPHI project. AMPLI-PPHI was launched on the heels of decades-long work, commitment, and progress across countries, and grounded in the research and global guidance that newer postpartum hemorrhage products will make a significant difference in maternal health outcomes. Across different contexts and at all levels of the health system, AMPLI-PPHI set out to support countries to catalyze the early adoption and scale up of these products to prevent, detect, and treat postpartum hemorrhage as part of existing maternal health systems. We wanted to demonstrate in real-life settings that the products shown here can be used effectively when they are available, and systems are ready and providers are equipped and supported. AMPLI-PPHI was launched in August 2022 in focused geographic areas of the Democratic Republic of Congo, Guinea, India, and Kenya, with Nigeria and Zambia joining in mid-2024. Our work, together with our partners FIGO and PATH, focused on 3 interconnected priorities: generating evidence to inform scale-up, strengthening enabling environments so countries can sustain progress, and increasing the availability of affordable, quality PPH commodities, and the focus of today's webinar. This slide highlights the reach and the scale of the AMPLI-PPHI project across the 6 countries and in more than 200 health facilities. These products were introduced at different times over about 30 months, and the picture is clear. Among the thousands of births across project sites, nearly all women giving birth received preventative care with heat-stable carbetocin. A calibrated drape was used to detect PPH, and among women diagnosed with postpartum hemorrhage, they were given tranexamic acid as part of the motive bundle. As Eva said earlier, today's webinar focuses on AMPLI-PPHI's work to improve product availability and affordability, including the challenges as well as the market and health system solutions. This is key. Recognizing wider access to health products is a critical piece in not only product availability, but also the ability of each country to fully integrate these products into their own health systems and move to scale. We want to thank you for being with us today in our last but not least webinar in our series. And Eva, back to you. Thank you, Eva.
All right. I'm thrilled that that worked and we got to hear Elaine. It's wonderful to have her set the stage. Our next speaker is Ms. Nao Godoy. Naoko brings over 25 years of experience across the private sector and global health, specializing in strategic planning, policy development, program design, and market development to accelerate introduction and scale up of health products in resource-limited settings. Her work has focused on expanding access to essential medicines, in vitro diagnostic technologies, and medical devices that improve patient care, empower healthcare providers, and enhance health system effectiveness in over 15 countries. As lead for market access at Jhpiego, she provides strategic leadership and technical guidance to accelerate the adoption, institutionalization, and uptake of new and underutilized products for maternal health and infectious disease programs. Naoko will present From Assessment to Action, Identifying Gaps and Shaping Interventions. Over to you, Naoko.
Great. Thank you, Eva. So if you joined the previous webinars in the series, you heard about how these tools can improve the prevention, detection, and treatment of postpartum hemorrhage. However, none of that matters if the products are not available where the clients seek care when providers need them. So as Elaine mentioned, today's session will focus on AMPLI-PPHI's efforts to improve the availability and affordability of these products. So this slide represents the framework that guided our approach to product availability, focusing on three interconnected dimensions: availability, affordability, and quality. First, availability. Estimates from Reproductive Health Supplies Coalition suggest that 69% of women in Eastern, Western, Central, and Southern Africa who need misoprostol and oxytocin do not receive them. But how much of this gap can be reduced if the products are made consistently available? That's the challenge we wanted to address. Second, affordability. Often the primary driver affecting the availability is the price or the cost of commodities. Most PPH drugs like oxytocin are highly commoditized, and there are many low-cost options. So switching to a new product that has higher cost can significantly limit availability, especially at the early stage of product introduction, until the budget can be adjusted. Even then, it may be challenging to secure the sufficient budget to meet the total need for a new, more costly product. So addressing the affordability is fundamental to improving availability. Third, quality. Many of us have seen the data on the high prevalence of substandard and falsified maternal newborn health medicines. Quality can be the flip side of the affordability, since high quality products can be, but are not always, more expensive. But the main point is that we want to improve not just the availability of any product, but the availability of quality assured products. So taken together, we use this triad approach to understand and address the multiple interconnected barriers that affect the availability of quality assured maternal health products. So when this project started 4 years ago, we first set out to understand the availability and affordability of three PPH medicines over our focus: stable carbetocin, tranexamic acid, and misoprostol. We assessed the availability of quality assured PPH medicines at the market level, project country level, and facility level using WHO pre-qualification and stringent regulatory authority approval as the quality standard. At the market level, we identify the manufacturers that have HSC, TXA, misoprostol products that are either WHO pre-qualified or approved by stringent regulatory authorities. We then review the registration data in each of the original project countries to understand whether HSC, TXA, misoprostol products registered in these countries are either WHO pre-qualified or approved by stringent regulatory authorities. At the facility level, we conducted a snapshot stock availability survey in sample facilities and disaggregated the data by whether the products are WHO pre-qualified or approved by stringent regulatory authorities or not. Finally, we also surveyed the facility prices of these products that are available at the time of the survey. Taken together, these assessments highlighted specific gaps for each product. For TXA, as you know, the drug itself has been on the market since 1960s. So not surprisingly, there is a high number of TXA products approved by SRAs, stringent regulatory authorities. We identified 46 at the time of the assessment. However, these products are rarely registered in low middle income countries. When they're available at the facility level, the prices of TXA products approved by stringent regulatory authorities can be almost triple the price of TXA products that are not. A glimmer of positive is that PPH indication can expand the market size quite a bit if the funding materializes, and this may be an incentive to attract manufacturers. For misoprostol, we found that WHO pre-qualified or SRA-approved products are widely registered in low-middle-income countries. However, similarly to TXA, their prices were found to be much higher. Since the PPH indication for misoprostol accounts for a small portion of the overall misoprostol market, we concluded that the opportunities for the market-level interventions through the project were negligible. For HSC, as we all know, the supplier base is very limited currently compared to other PPH products. We identified two manufacturers at the time of the assessment. One of these manufacturers, Ferrin, has a stable carbetocin product that is both WHO pre-qualified and approved by stringent regulatory authority, while another HSC product from a different manufacturer is not. To date, Ferrin HSC has been registered in over 30 countries. The biggest gap identified at the time of the assessment was the cost of HSC. Despite the subsidized pricing offered by Ferrin to the public sector buyers in eligible countries, the price of HSC is still substantially higher than the prices observed for oxytocin products available in surveyed facilities. Yes, many of these low-cost oxytocin products are not WHO pre-qualified or SRA approved, and thus the quality may be uncertain. But this is the baseline price that procurers will be measuring the HSC price against as they plan procurement. So if the price is the single determining factor for product selection decision, HSC has limited ability to compete on the cost alone. So we took these insights to consultations with the Ministry of Health and other stakeholders in project countries, and the Ministry of Health in each country identified a gap that they want to take action on with project support. So the speakers after me today will talk about some of this work that AMPLI-PPHI supported, including the tax reform as a price reduction strategy in DRC to improve the affordability, value-based procurement in Kenya to improve the quality, and global market intelligence work to improve the market availability. In addition, while the calibrated drapes were not yet recommended at the time of these assessments, based on the overwhelming interest, today's webinar will also feature a speaker to talk about early project learnings on calibrated drapes for those planning to procure for your national programs. With that, I hand it back to Eva. Thank you.
Thanks, Naoko. That was a fantastic introduction. And I know I learn a lot every time I hear you talk about the detailed work that the project needed to do at the beginning around availability, affordability, and quality at all different levels. So thank you so much for that presentation. I'm pleased to introduce our next speaker, Mr. Philippe Mukumbai. Philippe is a pharmaceutical expert dedicated to catalyzing systemic change in maternal health access and emergency preparedness across Africa. As a technical officer at WHO Kinshasa, he leads pharmaceutical policy development, ensuring medicine quality and safety, while building institutional capacity and coordinating multiple stakeholders. His expertise spans supply chain optimization, pharmacovigilance, and policy implementation. As the commercialization officer for Path with the AMPLI-PPHI project, Philippe spearheaded the DRC commodity access component, driving market shaping and health system strengthening for postpartum hemorrhage medicines. Philippe is a pharmacist by training and holds master's degrees in pharmacology and vaccinology and drug development. Philippe will present pricing strategies to increase availability with a focus on DRC. Philippe will present in French. Philippe, please proceed.
Merci Yva et merci aux organisateurs de m'avoir invité pour faire cette présentation. Et je tiens juste à préciser que je ne parle pas au nom de l'OMS, mais je parle comme étant quelqu'un qui a contribué dans le cadre de la mise en œuvre du projet AMPLI-PPHI. Et aujourd'hui, je veux vous présenter l'exemple de la RDC qui illustre l'utilisation des stratégies de tarification pour améliorer la disponibilité des médicaments essentiels pour la santé maternelle. Et le thème général de ces webinaires porte sur le passage à l'échelle des interventions. Et l'exemple que je vais présenter aujourd'hui montre que ce passage à l'échelle ne se limite pas seulement à l'introduction de produits ou encore à l'augmentation de l'offre. Il s'agit également de s'attaquer aux conditions politiques et financières qui déterminent si les médicaments essentiels sont abordables, disponibles et viables au sein d'un système de santé. Alors, cette diapositive présente les cheminements de la production des données probantes jusqu'à l'action politique. Le point de départ était l'enquête de 2023 sur les prix et la disponibilité que notre collègue Naoko vient de présenter tout à l'heure. Et cette enquête a révélé une disponibilité relativement élevée de l'oxytocine, mais une disponibilité beaucoup plus faible du misoprostol et de l'acide tranexamique. Cette enquête a également montré que les prix variaient selon les établissements et les régions. Et les résultats de cette enquête ont été présentés et discutés avec les parties prenantes du gouvernement lors d'une réunion consultative. Et la principale recommandation concernant la tarification était qu'il fallait renforcer les systèmes de réglementation des prix existantes. L'étape suivante a consisté en un atelier sur la tarification qui a été réalisé en juillet 2024. Et cet atelier a réuni les ministères de la Santé, le ministère de l'Économie, l'Autorité congolaise de régulation pharmaceutique, afin d'examiner les données probantes et dégager un consensus sur les réformes des prix. À partir de là, les parties prenantes ont élaboré une feuille de route comportant des activités à court, moyen et long terme. Cette feuille de route identifiait la réforme fiscale comme un domaine concret à analyser de plus en profondeur. L'enseignement principal est que ce processus était progressif. Le travail n'est pas passé directement des données à la réforme. Il a consisté à procéder par étapes. Donc, une analyse des données probantes, un dialogue avec les parties prenantes, l'élaboration d'une feuille de route, puis l'analyse spécifique de la réforme fiscale. Pour les passages à l'échelle des interventions, cette séquence est essentielle. Elle permet de garantir que les recommandations politiques s'appuient sur des données locales et sont prises en charge par les institutions chargées de leur mise en œuvre. Alors, l'atelier sur la tarification s'est appuyé sur l'étude relative au prix et à la disponibilité des médicaments. Et cet atelier poursuivait quatre objectifs. Le premier, il fallait comprendre les plans nationaux qui existent en matière de tarification des médicaments et puis partager les recommandations de l'OMS sur les stratégies de tarification des produits pharmaceutiques et aussi voir quels sont les compromis qui peuvent être liés aux différentes approches et discuter des mécanismes réalisables dans le contexte spécifique de la RDC, élaborer conjointement une feuille de route pour la mise en œuvre. Et les conclusions de l'atelier ont mis l'accent sur les actions concrètes qui sont présentées ici. Alors, les conclusions sont les suivantes. Les parties prenantes ont recommandé euh, la création d'un comité interministériel pour faire progresser les réformes fiscales, le renforcement de l'application des politiques de tarification existantes, l'exploration de l'approvisionnement basé sur la valeur pour les médicaments prioritaires et l'amélioration des systèmes de données sur les prix. Un message clé à retenir ici est que la réforme de la tarification nécessite la participation des parties prenantes adéquates, en particulier lorsque les réformes touchent au domaine des santé, des finances, des douanes, des marchés publics et des réglementations. Et cet aspect est crucial pour les passages à échelle, car les obstacles liés à l'accessibilité financière relèvent souvent des domaines extérieurs au programme de santé lui-même. Pour que les interventions bénéficient à un plus grand nombre de personnes, il est nécessaire de mettre en place des mécanismes qui vont permettre de relier les données probantes à une action interministérielle. Alors, cette diapositive présente la feuille de route euh, qui vise à renforcer l'écosystème de tarification des prix en RDC. L'objectif de cette feuille de route est de passer des recommandations générales à un plan d'action précis. Certaines actions peuvent être entreprises à court terme, tandis que d'autres nécessitent plus de temps, des systèmes plus robustes et aussi une coordination institutionnelle plus large. La feuille de route montre également qu'un écosystème de tarification repose sur plusieurs leviers politiques. Il peut s'agir d'une réforme fiscale, d'une réglementation des marges bénéficiaires des prix de référence, des méthodes d'approvisionnement des systèmes de données et aussi des systèmes de données sur les prix qui sont plus performants. L'étape suivante s'est concentrée sur les cas spécifiques de la réforme fiscale. L'objectif de l'analyse de la réforme fiscale était de voir comment les taxes et les droits influencent les dépenses publiques consacrées aux médicaments en utilisant l'oxytocine comme un médicament traceur. Et on a utilisé l'oxytocine parce que c'est un médicament essentiel pour prévenir l'hémorragie du postpartum et aussi parce qu'il fournit un exemple concret pour comprendre l'effet des coûts qui sont liés à l'importation. Comme je l'ai dit, l'analyse visait à produire des données probantes qui sont susceptibles d'alimenter les dialogues qui étaient en cours entre la commission interministérielle sur les réductions fiscales. Le point essentiel est que le droit et les frais d'importation peuvent augmenter les coûts finaux des médicaments. Et lorsque ces coûts sont élevés, ils peuvent réduire l'accessibilité financière et éliminer la portée de budget de santé. Et cela importe pour la couverture santé universelle parce que la réduction des obstacles financiers et l'accès aux médicaments essentiels peut aider le pays à atteindre davantage de patients sans nécessairement augmenter le budget. Alors, cette diapositive donne un résumé sur les résultats de la modélisation du scénario de réduction fiscale. Dans, dans la dia que je viens de présenter tout à l'heure, on a vu que le coût le coût estimé pour prévenir un cas d'hémorragie du postpartum est de 25 centimes par ampoule. Donc, ceci inclut les frais d'assurance, les transports, mais aussi euh, les coûts de transport, assurance, mais aussi les taxes et la distribution, liées aux taxes et à la distribution. Dans les scénarios les plus optimistes, si on fait une réduction de 99% de ces coûts, ceci va permettre d'économiser jusqu'à 7 centimes par ampoule et de prendre en charge jusqu'à 40% des patients supplémentaires avec les mêmes ressources. Et si le point de départ recommandé et qui est aussi plus modéré est de 50%, une réduction de 50%, qui est fixée entre 50 et 75%, ceci pourrait générer des économies significatives qui sont estimées jusqu'à 37 et 56 dollars pour 1000 cas d'hémorragie du postpartum euh, euh, prévenus. Mais ceci également pouvait préserver une partie des recettes au niveau des entrées portuaires. L'idée principale n'est pas que chaque pays doit supprimer immédiatement toutes les taxes. Il s'agit plutôt de montrer que les pays peuvent modéliser les compromis entre identifier une option de réforme qui améliore l'accès aux soins tout en restant financièrement réaliste. Alors, ce qu'il faut retenir de cette activité est que la réduction des taxes peut améliorer l'accès aux soins sans augmenter le budget de la santé. Et si le coût d'approvisionnement diminue, le même budget permet d'acheter davantage de médicaments et de prendre en charge un plus grand nombre de patients. Et des réformes modérées peuvent offrir un équilibre qui est juste et elles peuvent améliorer l'accessibilité financière tout en préservant certaines recettes publiques. Et ceci est important pour le passage à l'échelle parce que de nombreux obstacles liés à l'accès aux soins ne sont pas dus à un manque de preuves cliniques. L'intervention peut être connue, efficace et recommandée, mais ne pas parvenir à atteindre les patients en raison de son coût, des difficultés d'approvisionnement ou encore des obstacles publics. Alors, voici quelques recommandations destinées aux différentes parties prenantes. Pour le gouvernement et le ministère de la Santé, il est recommandé de réinvestir les économies réalisées dans les services de santé prioritaires, de créer ou de renforcer un organisme interministériel et de mener une analyse ciblée des compromis entre accessibilité financière et accès et recettes. Pour les acteurs de la mise en œuvre, il s'agit de produire des données probantes locales, de constituer des coalitions entre les pouvoirs publics et les sociétés civiles et d'investir dans des systèmes de données de suivi des prix. Ces systèmes sont essentiels car les réformes doivent pouvoir être suivies dans le temps. Et pour le bailleur des fonds, il est recommandé de financer la traduction des données probantes en politique et pas seulement les interventions axées sur l'offre. Les bailleurs de fonds peuvent également soutenir les dialogues interministériels et lier les investissements à des résultats axés sur la valeur, notamment la qualité, les rapports coût-efficacité et l'accès. En résumé, le passage à l'échelle des interventions exige plus que les simples disponibilités de produits. Il requiert un environnement politique favorable, des données probantes concrètes et une action coordonnée de toutes les parties prenantes. Euh, j'ai dit et je vous remercie et je vais repasser la parole à Eva. Merci de votre attention.
Thanks, Philippe. Terrific. It's hard for me to tell who is on, but I imagine there are several people on this webinar who just learned a lot from you about the road from evidence to reform. And it may be difficult, it may be tedious, but it's critical to ensure the actionable outcomes at the end of the day allow for these life-saving medications to reach providers and people who need them. Thank you so much. I certainly learned a lot. That was great, Philippe. I'm pleased to introduce our next speaker, Evelyn Wachuka. Evelyn is the Assistant Director at the Kenya Medical Supplies Authority, or KEMSA. She holds a master's degree in procurement and contract management, which has sharpened her skills in strategic procurement and supplier management, and a bachelor's degree in microbiology, which provides a technical foundation that complements her work in supply chain management in the health sector. She is driven by a passion of strengthening and ensuring sustainability of supply chain systems to deliver results that benefit public health. Evelyn will present to us today on value-based procurement for postpartum hemorrhage medicines with a focus on Kenya. Evelyn, please go ahead.
Thank you, Naoko. Good morning, good afternoon, everyone. My name is Evelyn Washuka, Assistant Director Procurement at the Kenya Medical Supplies Authority. Today, I will walk you through Kenya's experience implementing value-based procurement for postpartum hemorrhage medicines. I will cover our journey, key lessons, and practical examples of how VBP is being applied. Next slide, please. Okay, Kenya's transition to VBP has been gradual and evidence-based, evidence-driven. This started in 2023 with the pricing and availability survey that Naoko mentioned in our presentation. In Kenya, this survey was done across 72 facilities, which showed that quality assured medicines often cost more. Next slide, please. The next step was a pricing workshop that was held in 2024, where we explored pricing strategies, including reference pricing and markups, and developed a roadmap. Next slide, please. So later the same year in 2024, we had several stakeholders who reached a consensus on exploring using VBP and MCDA, that is the multi-criteria decision analysis, and confirming that MCDA is actually legally supported under our Public Procurement and Asset Disposal Act 2022 that governs public procurement. Next slide, please. So by 2025, the stakeholders who were involved explored how MCDA can be used to evaluate tenders for PPH medicines. And the stakeholders presented, they agreed on 5 criteria that can be used for tender evaluation. And each criteria was assigned weights. Next slide, please. So what are our next steps? Our next steps include validating the 5 MCDA criteria that were identified with an extended group of stakeholders, and then conduct a pilot procurement for selected PPH medicines. So what is value? What are we talking about value-based procurement? This is the practice of evaluating potential products, services, and solutions to maximize overall value for money rather than focusing only on the lowest purchase price. We realize that there's often a mistaken perception that procurement is only compliance driven, it is time consuming, and only an admin function. Procurement is often not looked at as an opportunity to drive value based healthcare, and we need to change that narrative. VBP is conducted using the same core principles as traditional procurement that include integrity, fairness, and transparency. But instead of the goal being to minimize price, the goal of VBP is to maximize value. And how is this done? This can be approached in several ways, but the key is multidisciplinary coordination between healthcare providers, policymakers, procurement teams, and clear definition of value criteria such as economy, efficiency, effectiveness, equity, and sustainability. Next slide, please. Different stakeholders have different values. How do we define value? Value criteria are different for different stakeholders. Stakeholders have an incomplete picture of requirements. For example, finance may only be looking at immediate budget impact and not understand the value criteria. Procurement staff may not be given full specifications. Physicians may be unaware of cold chain storage of products, operating or disposal costs. Also, you note that stakeholders change throughout the product lifecycle. Procurement staff may look at basic feature and cost. For equipment, the biomedical engineers may look at national standards or accessibility of spare parts. Clinicians may prioritize features that increase compliance. Policymakers may prioritize green packaging. And patients may prefer combination or extended release formulation. And that is why it's important, as mentioned in my previous slide, to bring together all the stakeholders and at the end of the day, to define overall value to inform VBP. Next slide, please. Value for money is central to the development of health policy in the delivery of healthcare. A healthcare system that delivers value for money is defined as one that maximizes efficiency, enabling the population to attain the highest possible level of health, given the level of expenditure. Therefore, value-based procurement is one mechanism to help ensure we are delivering value for money. Next slide, please. In Kenya, value for money is already embedded in the policy. We have key policy documents, the first one being the Public Procurement and Asset Disposal Act, which emphasizes on maximizing value. We also have another national document, the Policy and Regulations 2020, which calls for evaluating costs, benefits, risks, and non-price factors. Similarly, the Public Finance Management Act defines value for money as efficient and effective use of resources. So VBP is not something new. It is aligned with existing legal and policy framework. Next slide, please. Let's look at value-based procurement versus traditional procurement. Traditional procurement focuses primarily on lowest price and short-term needs. In contrast, value-based procurement is strategic, it is long-term and evidence-based. It includes input from multiple stakeholders from the beginning. It involves early supplier management to understand market dynamics, and it uses total cost of ownership and not just the purchase price. Bid evaluation includes multiple criteria and not just cost. And importantly, it emphasizes contract management and performance tracking. Overall, VBP transforms procurement into a strategic function. Next slide, please. How Kenya is using VBP for PPH products. We have applied value-based procurement principles to PPH medicines procurements. Firstly, we updated specifications in our tender documents to prioritize quality-assured products. For example, we restricted tenders to WHO pre-qualified and SRA-approved oxytocin. We also improved quantification based on the introduction of new products like heat-stable carbetocin. Most importantly, we introduced multi-criteria evaluation, including the 5 criteria: product equivalence to originator product, manufacturing quality, pharmacovigilance systems, supply reliability, company sustainability. This ensures we are selecting suppliers based on overall value and not just price. Next slide, please. Lessons learned in Kenya from our experience with the introduction of heat-stable carbetocin. And Kenya's experience has shown that successful procurement goes beyond purchasing medicines, requires strong leadership, strategic planning, and collaboration. Firstly, the Ministry of Health, leadership, and ownership were critical in mobilizing domestic resources, resulting in the procurement of over 540,000 doses of quality-assured HSC, that is the heat-stable carbetocin. Secondly, affordable pricing significantly increased access. The reduction in price from approximately 2,700 Kenya shillings to 95 shillings per dose made it possible to scale up access across public health facilities in all 47 counties in the country. Thirdly, we note that supply alone is not enough, you need demand. We invested in awareness, training, and engagement across different stakeholders. And this is what helped achieve adoption across the 47 counties. We also learned that accurate forecasting is essential. Demand grew much faster than anticipating, highlighting importance of using facility-level consumption data. We also found that partnering with experienced domestic distributors is essential, as they are better positioned to navigate local regulatory requirements and help reduce importation and distribution delay. Finally, sustainability is key. While domestic funding was essential, long-term access may require innovative financing approaches to maintain scale up. Thank you, and back to you, Eva. That is the presentation from KEMSA, Kenya. Thank you.
Thank you, Evelyn. That was terrific. What a good reminder of value and telling us right at the beginning that this has to be nested within fairness, equity, and transparency. We can't just look at price alone. So thank you for spotlighting Kenya and the policy procurement in the context. I'm sure there are people on here who have learned from that and can take some of those learnings from Kenya to integrate VBP in their settings. Thank you so much. I'm pleased to introduce our next speaker, Ms. Rosemary Njogu. Rosemary is a registered nurse midwife with over 16 years of experience and a master's degree in community health and development. She's a senior regional clinical advisor at JPIGO, leading immunization, nursing, and midwifery initiatives across Africa. Her work spans HIV, RMN-CH, and maternal vaccines, including COVID-19, with contributions to research. A 2024 Women Lift Health Fellow and Daisy Award recipient, she is also passionate about mentoring young women leaders. Rosemary will present to us today on calibrated drapes, what we're learning about the product. Rosemary, over to you.
Thank you. Thank you. Thank you so much, Eva. Good morning, good afternoon, and good evening. I'm delighted today to continue with the conversation. And as you well know, choosing the right product is critical to improving the early detection and management of postpartum hemorrhage. But equally important is ensuring that these products are available, affordable, and fit for the local context. Having a product which can be able to accurately measure blood loss is key for timely intervention. In 2023, WHO recommended a routine objective measurement of postpartum blood loss for all women giving birth to improve early detection and timely treatment for postpartum hemorrhage. This is important because healthcare providers previously relied on visual estimation of blood loss, which is often inaccurate and is resulting up to 50% of PPH cases being missed. Delayed recognition of excessive bleeding remains a major contributor to preventable maternal deaths, and it's key to emphasize the importance of using appropriate product for objective blood loss measurements to improve quality of care and support better maternal health outcomes. Within the project, 4 products were considered. The calibrated drapes. We considered the non-biodegradable single-use drape. We also considered non-biodegradable single-use pouch with reusable mats, biodegradable single-use pouch with reusable mats, and biodegradable single-use drapes. These reusable mats were decontaminated and dried before each reuse, and standard operating procedures on decontamination were set for these facilities to ensure that infection prevention control was in place. On product selection across the countries, including type of the calibrated drapes, this varied significantly across countries and was strongly influenced by the Ministries of Health experience. Other factors included the Ministry of Health preference, previous experiences, approval by relevant national regulatory authorities, product specification, calibration markings, critical threshold markings, shelf life, lead time, price, waste management requirements, and capacity of the countries and origin of the manufacturing of this product. Some of the considerations informed product selections across the countries. And let me just unpack a few of these key considerations. The local market investment versus the international procurement importation. Local investment improves availability. It also increases low costs, building the national capacity to be able to manage the blood measurement tools, ensure sustainability. Also strengthening local manufacturing and supply chain to reduce dependency on importation. This is key because they will increase availability within the country. In contrast, international procurement may increase costs, delay in supply, limited responsiveness to local needs. For sustainability, focusing on building the country local production with locally available materials may be key as we move on with objective measurement tools. Other consideration included incineration of non-biodegradable products versus the safe burial for biodegradable products. Waste management, just similar to other waste management or contaminated materials in hospital, for calibrated drapes, it's key. And as you well know that incineration is considered as priority to prevent environmental contamination. For biodegradable products, however, can be safely disposed of through environmental friendly burial methods and minimum harm to the soil and water supply. However, having clear MOH protocols on decontamination and use of calibrated drapes before safe burial is required. Another consideration which was key was disposal of single-use products versus disinfection of reusable mats with disposable pouches. The use of single-use items has significantly impact on the environmental and cost implications, particularly due to the large volumes of the medical waste that is generated. Where safe and feasible, reusable mats should be properly disinfected and used along with disposable pouches. This combined approach may help reduce waste, lower costs, promote more sustainable healthcare practices while maintaining strong infection prevention control standards. Ministries should make informed decisions to ensure that the balance between safety, cost effectiveness, sustainability in procurement and implementation decisions. Within the 6 countries, I want to really just unpack on how this introduction was made across the countries. In early 2025, Nigeria and Zambia calibrated drapes were introduced as part of the clinical training in the broader PPH prevention and treatment. Well, in the original countries, Kenya, India, DRC, and Guinea, they used a mix of single-use calibrated drapes with non-biodegradable single-use pouches and reusable mats. In some countries, manufacturing origin and local production was a major consideration for this. And a good example was Nigeria, where the government prioritized engaging the local manufacturers to strengthen sustainability and future domestic production. And largely, these manufacturers used the single-use calibrated drapes. Product choices evolved across various countries as the countries gained experience and also refined priorities. For example, in Zambia, they transitioned from non-biodegradable single-use pouches with reusable mats to biodegradable single-use drapes. And at one point, they used biodegradable single-use pouches with reusable mats. That shows how countries, where learnings go on, then they are able to transition to what is more comfortable to the country and a product which is more visible for that country. The journey provided many variable learnings, and we gained experience over time across the 6 countries. And some of the key learnings on the product, the healthcare providers across the 6 countries really preferred more bold markings as per the 300 mils mark and 500 mils mark. And this is because it would be easier for them to check easily when they are required to give intervention to treat PPH. String length also mattered, and this significantly was mentioned in Nigeria, where the length of the strings to be able to fit the women comfortably and putting into consideration the various sizes of the women coming to the maternity. And then durability of the material. This was highly highlighted in Zambia, where we had biodegradable drapes, and they requested a more durable material to enable the pouches sustain the blood at even 500 mark. Then the size of the drape. In Nigeria too, they had requested large drapes to be able to fit all sizes of women. Largely mentioned across the 6 countries was the comfort of the drape, and some providers reported that the polythene material was uncomfortable when women stayed on the drapes for a longer time. And so various manufacturers were given feedback to ensure that they were able to give a more suitable and women-friendly material. Thank you, and I want to take it back to Eva.
Thank you so much, Rosemary. That was fantastic. And the calibrated drape can be a game-changing tool. You talked a lot about that on the first and second webinar. And then with it, we can quickly and precisely detect PPH in order to initiate treatment in a timely manner. But they're more than just a plastic pouch, right? And there are lots of considerations to take into account before procurement and introduction of the calibrated drape, as you've laid out for us. Thank you so much. Participants, please put any questions that you may have in the Q&A. This is your chance to query the experts around all of the topics that they're presenting today. Our next speaker is Mr. Mike Rufo. Mike is a market access specialist with over 15 years of experience in product introduction, market shaping, and health system strengthening in low and middle income countries. He's a senior market access officer at PATH, based in Geneva, where he supports multi-country initiatives to improve access to essential medicines with a focus on maternal and child health. His work includes pricing analyses, demand forecasting, investment case development, and leading large-scale implementation projects to support product uptake. He has worked closely with governments, donors, implementing partners, manufacturers to operationalize global access strategies and drive country-level adoption. Before joining PATH, Mike held roles at the Bill and Melinda Gates Foundation and the University of Washington Department of Global Health. Mike will round out the webinar today with a presentation using market intelligence to improve availability of affordable HSC and TXA. Mike, please proceed.
Thank you, Eva. So we've heard how AMPLI-PPHI has informed product selection of calibrated drapes and supported affordability through tax reform in DRC and quality through value-based procurement in Kenya. I'd like to build on that by describing the global market intelligence work we conducted to improve market availability by addressing some of the broader barriers facing TXA and HSC. As you heard earlier, the starting point for this work was product-specific challenges that we identified through a series of assessments. For TXA, we found that quality-assured products were not widely registered in LMICs, and where they were available, they were more expensive than non-quality-assured alternatives. For HSC, we identified a limited supplier base, raising concerns that a healthy, resilient market would require a more diverse base. To build a business case for improving supplier diversity, we needed more information about the markets. Could we demonstrate there was a viable market? Could quality-assured products compete? Would future demand justify investment by suppliers to enter the LMIC market? Were there barriers to new suppliers entering? And once products were available, how could they best reach the patients? Those questions were the basis for the 5 analyses shown here. Each one was designed to reduce a different source of uncertainty and together build a stronger case for the market entry and sustainable scale-up. So markets for maternal health products are often opaque. We rarely have clear data on where products are available, how they are moving through the supply chain, or what prices are being paid. To overcome this for TXA, We started with the fact that India supplies more than 60% of TXA registered in African countries, and we used India export data as a proxy to better understand the overall trend of the TXA market. That data set covered more than 2,400 transactions and nearly 300 million doses exported between 2021 and the first half of 2024. What we found was that LMICs represented about 12% of total Indian TXA exports, or about 9.6 million 1-gram doses from 2021 to 2023. Within that share shipped to LMICs, we saw that demand is highly concentrated. 14 countries, shown on the right, accounted for more than 70% of imports into LMICs. Further, we saw that 10 countries accounted for 87% of exports to Africa. And we also saw that Kenya, DRC, and Tanzania together represented about 90% of East Africa community demand. So the key takeaways here are the majority of TXA products are going to high-income countries, which confirms the seeming lack of interest by manufacturers to serve LMIC markets that we saw in the registration data in the initial assessment, and that 5 milliliter presentation, as opposed to the 10 milliliter presentation, is more commonly procured in LMICs. The implications of this will be discussed in a webinar on July 9th. So there's a teaser for you. This work made an opaque market more visible and gave us a basis for thinking about where to focus supplier engagement, where to support appropriate uptake, and how to interpret the pricing data that comes next. So using the same export data set, we looked at order size and price per 1-gram dose for TXA shipments to LMICs versus high-income countries. We saw that LMIC transactions were typically smaller and more expensive with larger price variations. The median LMIC order was about 12,500 doses, compared with 88,000 doses for high-income countries. The median price was also higher, at about $2.50 per dose, compared to $1 per dose in high-income countries. On the other hand, in high-income countries, price variations are much smaller, regardless of the order size. This suggests that it's not the order size that is increasing the price for TXA and LMICs, but something else. So the issue is not if affordable quality assured TXA exists, it is whether those suppliers have enough incentive to enter or expand into LMICs. So to answer that question and illustrate the opportunity associated with the use of TXA for PPH treatment, AMPLI-PPHI developed a 10-year demand forecast. Our demand forecast suggests that TXA presents a growth opportunity for suppliers, with the growth largely driven by the PPH indication, building on the relatively stable market for surgery and emergency indications. So this shows that by 2035, the PPH indication is forecast to represent about 5.3 million doses, compared with roughly 1.1 million today. We expect early growth to come from AMPLI-PPHI focus in exchange countries, with broader LMIC demand increasing in later years. This growth should provide incentive for manufacturers to enter the market, and when coupled with value-based procurement to support conditions where quality-assured products can compete, we can build a case for manufacturers to enter these markets. So now, shifting to heat-stable carbetocin, we wanted to understand whether future demand could support additional suppliers. One quick note on method for this. Unlike TXA, which has several indications, HSC currently has a primary indication for prevention of PPH. So we made assumptions that a portion of the oxytocin market for PPH prevention will transition to HSC, especially where cold chain capacity is limited. In short, as you can see at the top of the slide, of the 120 million births annually in LMICs, we estimate that as many as 71 million births could use HSC for PPH prevention. On the bottom left, you can see that the overall urotonic market for PPH prevention stays relatively flat at around that 71 million doses, but the share of HSC versus oxytocin shifts significantly. HSC grows from about 2.6 million doses today to roughly 62 million doses in 2036, displacing oxytocin rather than adding to the total. Again, the growth is driven at first by AMPLI-PPHI focus and exchange countries. So this gives suppliers a clear growing demand signal and is the basis to support continued and potentially increased investment in HSC. So the next question was, if additional suppliers are needed to sustain a healthy market, what barriers to entry might they face? So we looked at whether intellectual property could be a barrier to entry for additional HSC suppliers. This analysis found that patents are unlikely to be the primary barrier to entry for new HSC products for suppliers focused on African LMIC markets. The existing patents are primarily concentrated in higher income markets with limited coverage in Africa, where patent coverage was identified only in Morocco and South Africa. This matters because it shifts the focus from intellectual property concerns to other conditions that may discourage suppliers from market entry, such as distribution strategy. So speaking of distribution strategy, distributors are the link between manufacturers and the health systems that need these products. So we wanted to address the question, how should manufacturers select distribution partners to enter or expand into LMICs? To better understand the distributor landscape in Africa, we analyzed registration data from 10 countries, covering nearly 60,000 pharmaceutical registrations and more than 2,000 unique distributors. We also interviewed 34 distributors across Africa. The analysis showed that distribution networks are highly country-specific. 83% of distributors operate in only one country. And within individual countries, registrations were often concentrated among a relatively small number of distributors. The top 10% of distributors held between 44% and 70% of registrations, depending on the market. We also saw substantial variation across markets. So with 5 countries shown on the chart, accounting for 80% of all registrations. The implication of this is that region-wide entry will likely require country-specific partnership strategies. And the level of concentration in each country impacts the entry strategy that a company can take. So, distributor intelligence helps manufacturers make informed decisions about distribution partners in each target country, influencing whether the product can actually reach the facilities and patients that need them. So we'll be posting this full report on distributor landscaping on the future AMPLI-PPHI dissemination website. So where does this take us? So when we started this work, we knew there were too few quality assured TXA products registered in low and middle income countries and a limited supplier base for HSC. We wanted to make a case for increased investment for market entry. Together, these market analyses paint a picture of market growth in LMICs and provide business insight into how to enter this market. Rather than asking manufacturers, governments, donors, and partners to make decisions based on assumptions, we were able to provide evidence on where demand exists, where growth is expected, and what barriers remain in improving market availability of these products. This connects to the earlier presentations. Tax reform and value-based procurement work to improve the availability and quality assured products within each country, while this work builds on the business case to encourage manufacturers to make quality assured products available in LMICs. So ultimately, market intelligence isn't just about understanding markets, it's about reducing uncertainty. When decision makers have better information, they make better decisions, and better decisions create the conditions for sustainable markets with equitable access to life-saving maternal health products. And as you'll hear at the close, this is the groundwork for the next wave of projects to build on. Thank you. Over to you.
Thanks. Thank you so much, Mike. All of these presentations have been incredible. I wish we had more time than we do to answer all of the questions that we're getting. We didn't have many at the beginning, and then people have started putting them in now. So it is time to open the floor for our few questions. So let me take a look in the Q&A, and then I'll get with our speakers. Okay. Actually, Philippe, so a reminder to everybody that we do have French speakers, so stay in your preferred channel so you can understand the responses when we get them back in French or English if it's not your preferred language. Philippe, let me ask you the first question. I'll do it in English. Your recommendations highlight the importance of cost-effectiveness analyses. Could you share the cost-effectiveness analyses conducted on these new innovations for the prevention and treatment of postpartum hemorrhage? So I think the question is whether these are available and whether or not people can see these tools and use them. Over to you, Philippe.
Oui, merci beaucoup pour la question. Et comme je l'ai dit, l'analyse des coûts-efficacité est importante pour les nouvelles interventions parce qu'elles permettent de savoir si les bénéfices obtenus justifient les ressources qu'on investit. Et pour les cas des nouvelles interventions pour la prise en charge des hémorragies du postpartum, il y a ces analyses qui ont été réalisées pour la carbetocin thermostable et l'acide tranexamique. Et il y a des données qui sont disponibles, des publications qui sont disponibles sur Internet. Et les conclusions de ces analyses montrent que, par exemple, pour la carbetocin thermostable, et c'est une stratégie qui s'avère être qui a un bon rapport coût-efficacité pour la prévention des hémorragies du postpartum. Maintenant, pour les pays qui introduisent cette intervention ou qui veulent passer en échelle, il est important de comprendre quels sont les autres obstacles qui peuvent qui peuvent empêcher que ces médicaments, ces interventions puissent parvenir le patient qui en a besoin. C'est là que le travail doit se faire au niveau de chaque pays pour comprendre d'où proviennent ces barrières et comment les éliminer. Merci beaucoup.
Thanks, Philippe, so much. I know that was very helpful for both the person who asked the question and the rest of the audience. We've got several for you, Rosemary. They're in the chat. I think you've seen them. So there's lots of questions about drapes, but in summary, to me, they're really about the specs. So have manufacturers looked at making drapes more comfortable? Have manufacturers looked at making drapes more adaptable to different types of delivery positions or beds? And then we get this question all the time, which is how do we really think about drapes in the context of also having maternal well trays? So I asked you 3 questions and you have a really short time to answer them. Over to you.
Thank you. Thank you, Eva. And I want to start off from at the manufacturers getting the feedback. Maybe that's where we should start from. And are they making any efforts to make sure that they align the drapes to the feedback? My answer is yes, because early feedback in Zambia and Nigeria enabled the manufacturers to switch and be able to have drapes which are more comfortable. And when you look at the material on the initial drapes, over time, this is evolving. I want also to really mention that this is a conversation which has been going on basically for around 2 years or so. So the manufacturing and the feedback, I would say it's optimal and we have changes going on. When it comes to the beds versus how the drapes are fitting, we have a case scenario for Kenya whereby initially in the rural settings of Kenya, when they introduced the drapes, they realized the maternity or the labor ward beds were not fitting well because they were not standard delivery beds. And so there were two ways. They gave feedback to the manufacturer, but also it was an opportunity for them to advocate for the government, and they got the Makueni County having to procure some beds for some facilities. But also the manufacturers have changed a bit, increasing the length of the strings and making the drapes slightly bigger to be able to fit birthing positions, even when mothers are squatting. And if you look at various drapes, the Sinapi drapes as an opportunity to even be able to deliver a mother while squatting equal to other drapes. And this is evolving day by day. On the question of maternal well versus the drape, this varies from country to country. I know in Sierra Leone and other countries, the maternal well has done well, and it's more durable. We don't need to dispose it every time. However, it has gotten also a few not very good feedback in some countries. And so this is dependent on country and government choice. And so we have an opportunity to either use the drape or the maternal well. Thank you. And back to you, Eva.
Thanks, Rosemary. It's such a hot topic, and the drape space is really evolving very, very quickly. And so I imagine we'll continue having these conversations. Thank you so much. There are other questions in the Q&A. Presenters, please try to answer those in writing in the answer box. We've run out of time and reached the end of our Q&A session. But thank you to all of those who submitted questions and all of those who responded. Next slide. Okay, great. And so with that, we've reached our closing remarks, and I'm really thrilled to introduce Dr. Sheun Aladesami. Sheun is a global health systems market access and supply chain expert with over 20 years of experience. He currently serves as technical manager of strategic sourcing and supply at Unitate in Geneva, leading initiatives to improve access to critical health products, working across multiple portfolios, including M&H, regional manufacturing, malaria, and oxygen. Sheun, thank you so much for agreeing to provide closing remarks for us today. Over to you.
Thanks, Eva. And I hope everyone can hear me well. It's really hard to come in after all of the amazing speakers at this session. So I just want to start by saying many thanks to all of the speakers for the insightful and engaging presentations, but also the participants and audiences on the discussions and questions on PPH product access. Your practical perspectives, country experiences are very valuable to advancing access and strengthening supply chain systems for maternal and newborn health products, particularly the life-saving PPH products. So we do appreciate your time and your contribution. As we close today's discussion, I would like to leave you with 3 reflections from the discussions and also talk about how those reflections are informing the future of Unitate's investments in postpartum hemorrhage products. First, we've learned from all of the webinars and the sessions before today and today that it's not just about one product, but it's about a system to deliver care and all of the necessary products to the patients that need them. We know that we already have a strong set of WHO recommended tools, but the real challenge is ensuring that they're used together as part of the integrated package, and to ensure that all of those products are available in the right quantity at the right time, and that means they require accurate forecasting and timely procurement. So Unitate's project like AMPLI-PPHI continue to generate the operational evidence and support countries to introduce these products, not just in isolation, but generate the learnings that will address the barriers that undermine access. And that's, we mentioned before, adoption, availability, quality, and affordability. So in response to these persistent barriers, Unitate seeks to catalyze improvements in national supply chain performance through targeted country-led interventions that address critical systemic bottlenecks. And if approved by the board, Unitate will implement Inspire, which is a proposed investment that will focus on strengthening key enablers of product access. And that includes issues around coordination mechanisms, forecasting and quantification, financing, procurement, regulatory processes, and last mile delivery. And all of this will be done to improve the availability and equitable distribution of priority maternal newborn health products. The products will generate evidence on innovative and scalable approaches, foster cross-country learning, and support community and civil society engagement to accelerate improvements in maternal newborn health product access, while we do this to optimize the use of limited resources. Secondly, we must close in the persistent gap between global guidance and country-level access, something that's come up repeatedly. We see that the pathway from WHO recommendations to routine use is still long, especially for countries in LMICs. And United is tackling this by investing in late-stage clinical evidence. We do this through Transform and Reach, while also supporting policy translation, regulatory acceleration, and country uptake. So we've launched a regional manufacturing portfolio as part of our Safeguard Africa project, termed Regional Manufacturing for Equitable Access. It is an end-to-end manufacturing strategy to increase regional manufacturing of quality assurance medicines in Africa to expand equitable access. The therapeutics components called Medicine Supply Resilience, MedSure Africa, is being implemented by USP, and within its scope, they will be supporting a number of regional manufacturers of PPH products such as heat-stable carbetocin, calibrated drapes, misoprostol, oxytocin, tranexamic acid in a number of countries like Ghana, Nigeria, Kenya, and South Africa. There is also a diagnostic component, which is term made, which will be led by PATH. But as part of this project, we will be strengthening regulatory processes and regulatory harmonizations to reduce regulatory delays. And to that end, United just signed an MOU to work with the African Medicines Agency, and that work will work on regulatory processes for health products, which will also include PPH products. And in addition to MedSure project, there is a PPH demand country component that will be implemented in Cote d'Ivoire, Ghana, Kenya, Rwanda, Tanzania, and Zambia. This will include implementation of a series of demand and strengthening enabling environments across a number of countries. And that would prioritize interventions related to postpartum hemorrhage diagnosis and address all of the issues around some of the barriers that we mentioned earlier on. So also just want to highlight some of the market intelligence work that were foundational by AMPLI-PPHI. Those were the key foundational market intelligence work that has really informed the follow-on work by United that will be taken up, that is being implemented in regional manufacturing. So thirdly, the future of the products will be shaped by markets, and that is where and how products are made, how they are financed, and how they're delivered to patients. And without this reliable supply, competitive markets, and sustainable financing, even the best products will not reach those who need them. Which is why United's work continues to be important in catalyzing healthier markets through multiple levers, supporting regional manufacturing, strengthening supply security, exploring pool procurement and market shaping approaches to ensure that products continue to be available. So as a result, as part of the regional manufacturing platform, we'll be exploring different private and public partnerships and strengthening pool procurement mechanisms. We recently signed an agreement with the Africa CDC pool procurement mechanism to catalyze the fund to ensure advanced payment to regional manufacturers. We'll also be working with SADC, EAC, and WAHO, some of the regional bodies as they design and plan to implement their pool procurement mechanism as well. And all of this work will be linked to our upcoming United-funded work, Inspire, that I mentioned. So if I were to summarize the future PPH products in terms of United's scope and investment, I would say it's all about integration, regulatory acceleration, coordination, and sustainability, integrating the products into the care systems and the systems that deliver the products, that includes supply chain systems, accelerating access from evidence to scale, ensuring coordinations among donors and partners, and building sustainable, resilient markets, including through regional manufacturing and strong procurement mechanism. And we'll continue to be heavily engaged in upcoming supply chain conferences like the Global Health Supply Summit coming up in November, and other maternal newborn health projects and regional manufacturing and regulatory conference. So I just want to say that while individual unit projects may end, our commitment to postpartum hemorrhage, product access, and the broader portfolio for maternal newborn health will not end. We'll continue to build on all of the foundations and these learnings to support the next generation of investments, which will be focused on strengthening systems, markets, and country ownership to ensure that access to life-saving PPH products becomes the norm. So I want to thank everyone for your participation in this webinar, and we look forward to more engagement as we continue to ensure access to PPH products. Thank you and have a good rest of your day.
Terrific, Shim. Thank you so much for your reflections, for those insights into Unitaid's thinking, and for the assurance that access to PPH products will continue to be on everybody's mind. And thank you to all of our presenters. I know how much work it is to put a webinar as complex as this one is together. I know that people learned a lot from listening to you this morning. I hope all of you who did join, thank you, that you've enjoyed them as much as we have enjoyed sharing them with you. Next slide. Well, we're getting this slide up. Just a reminder that if you haven't had enough and you weren't able to come to all of our webinars, they will be recorded or they have been recorded, and you will get a link to those recordings in your post-webinar email. There'll also be a QR code here that you can click to access the online repository where the recordings will be. And if you want even more, on the right QR code, AMPLI-PPHI is partnering with the tranexamic acid access for all mothers with bleeding after childbirth project, or TRANSFORM, led by the London School of Hygiene and Tropical Medicine, for yet another webinar, which will be on the 9th of July, during which we'll look at how new evidence and innovations can expand access to tranexamic acid. So please join us there, and the QR code will allow you to register. The QR code on the left is another way to access the AMPLI-PPHI supplement and the International Journal of Obstetrics and Gynecology. Thank you all again so much for joining us this morning. We wish you a good day.